All right, guys, welcome back to part two of our intro to Medicare series with me and Mike Amsbaugh. Right now, what we're going to go through is what I talked about we would do in the early part of part one of the series. We are going to go over kind of just how to do like a mock presentation, what to ask for, what to make sure you get, what you need to make sure you're kind of saying just to sound like you're kind of educated, and how to run through Sunfire, how to quote and compare, what plans they might be on right now, how to be able to locate the plans that they're on, make sure you're quoting apples to apples, and just what everything we need to do. Make sure you've got a basic understanding of when you get in a house, what you need to do. So, all right, Mike, ready to take it away?
Yes.
Cool, man. So
Basically, I will say this. We're already at the table. We talked about that before. And then when I'm sitting there and I'm talking to, let's just go with Miss Donna here, since I just enrolled her last week. When I sat down with Miss Donna, again, I would just kind of reiterate at the table what I told her at the door. Hey, like I said when I was standing at the door, I'm here to just kind of go over all the different benefits that you may be eligible for. Look and see what you currently have. If there's anything you're not getting, I'm gonna see what I can do about getting it for you, right? So, Miss Donna, do me a favor real quick. Do you have your red, white, and blue card handy so I can pull you up in our system? And it basically, I'm sure you know what you got, but it tells me in detail what you have. That way I know if you're missing anything. And so Miss Donna and she did. She got up off the chair, went and grabbed her red, white, and blue card, brought it back. And I have always I could probably tell her to just go get all of her medications and stuff as well. For whatever reason, I've always just get the red, white, and blue card first. I will go ahead and pull that up in the system. I will say view quote. I try not to overwhelm, our clients, man. They're kind of old. They're not always with it. So I try not to overwhelm them too much with too many commands at once. So once she brings that to the table, here's where you would be. You would here's what it's going to look like. You would put in her zip code, which you probably already know because it's on the lead that you had in your
where did you click on that from the home screen?
This is the home. Well, okay, let me go back. So we would technically be here. Quote and enroll is where you would start. But if I do that, it's going to take away her information.
Okay, cool.
So technically, if you hit quote and enroll, it will bring you to this screen right here. Boom. That is the quote and enroll screen.
All right. So now you put in her zip code. You put in what county she's in.
Zip code. She's in Marion County.
And you put in her date of birth. And you hit save.
Red, white, and blue date of birth. And then you hit save. And it was going to look up her information. Boom, so, right there.
Everybody knows the red, white, blue, the card we reference is the card that they get when they turn 65, correct? Everybody gets one when they go on Medicare, right, Mike?
Mm-hmm.
Okay, cool. So it looks like an American flag. It's red, white, and blue. Everybody, if they're on Medicare, they're going to know exactly what you're talking about. They should have it. They generally always have it right in their wallet or their purse, like that. Most people always have to carry them. So real easy to know. So it's not like you're asking for something crazy where they're going to look at you and be like, what are you talking about? Everybody knows what their red, white, and blue card is.
Yeah, I mean, it is implied. I'm talking about their Medicare card. It's just a word that I don't feel the need to say. You know what I mean? They know what I'm talking about when I say grab your red, white, and blue card. So you popped all that information in. It populates her Medicare information. Her Part A effective date, which is the same for most people. It will be. A and B will be the same. She took it on 8/1/16 when she retired. This system tells me, and it didn't always, Sunfire has done some really good updates in the last 12 to 24 months. It tells me she's eligible for Medicaid, and it tells me that she has LIS level 1 already. So those two things are completely different. A lot of people lump them in and think it's the same thing. It's not. You can have LIS and not have Medicaid. But on the flip side of that, if you are low enough income to have Medicaid, they automatically give you the LIS, which is low income subsidy, extra help. It is a federal benefit through Social Security. It helps subsidize the cost of your drugs, and it basically lowers the copay that you have to pay at the pharmacy. Okay. So that is what LIS is, and level 1 is the best one. Your drugs will be between $4, $1, like $1.30 and $4 and some change. But I just say 1 and 4, and then level 2. It used to be 4 levels. They simplified that last year. You may still see some 3s and 4s in the field right now, but as of 2025, it'll just be 1 and 2.
Okay. Now, is there a high chance that I could sit down with Miss Betty and she may not even know she's eligible for Medicaid?
That actually happened with this lady. So yes, that's a solid. But here's the thing. So I'm going to preface all of that by saying this. This system recognizes that Miss Donna has a Medicaid number attached to her name. The unfortunate part is it doesn't tell you whether it's active or not. A Medicaid number is like a Social Security number, follows you around for life. It doesn't change. So she may have had one in the past and it not be active right now, but the system is going to say eligible for Medicaid. I wish it was worded different, because eligible for Medicaid makes it look like, oh, Miss Donna is eligible for Medicaid, just like it sounds. Really, the system's just seeing that she has a Medicaid number attached to her name. There is oftentimes when I see that, and then I dig a little deeper, and the Medicaid number is inactive, and there's nothing you can do there as far as dual plans. But in this case, as you can see right here, she was in an Aetna Medicare Premier HMO POS, which is a non-dual plan. Technically, she should have been in a dual plan. She had no idea that she had a low-level Medicaid.
All right. Now, with that, it would say you find out she's no longer eligible for Medicaid. Is that because maybe all of a sudden she makes a little bit too much money every year and she lost Medicaid? At that point,
that's the only reason you'll be booted off of Medicaid, is if your income or your assets are above the threshold.
Now, let me ask you this, Mike. Okay. When they take in eligibility for Medicaid, do they account for how much money they get in, let's say on a food card? They don't add that in. They only go by what's on their W-2 at the end of the year, which says how much money they made off Social Security, right?
But basically, it would, the extra benefits that are built into these advantage plans are never factored against them. It is any type of retirement that they're taking a draw off of. So yes, basically what they would be claiming on their taxes, whether it be like, widow's pension or something of that nature, all that gets factored in. But it is basically off of income and assets, not benefits built into plans.
Okay. All right. Perfect. Cool. Just want to clarify that for everybody, because they didn't like think all of a sudden, oh, they got too much stuff coming in with extra help. They can't get it. There's a high chance. Now, is there a system? And great, I know we're going kind of deep here on the Medicaid thing. Is there a system that I can punch Miss Donna's info into to figure out where she's at in her eligibility, if it's active or not?
Yes. Most of our portals, yes and no currently. Yes, there is currently the Medicaid checker with almost every carrier. Every carrier has one built into their portal you can check. We're having to call in right now. There was about 3 or 4 months ago, we had nationwide hackers hacked into the Medicaid system and basically shut the system down. So these carriers are having to jump through a lot of hoops to verify Medicaid numbers right now. And those programs that were built into the portal pages, or the portals that like United Healthcare or whatever, they don't give us the numbers right now, or they don't give us the information now until everything comes back online.
Okay. All right. Perfect. So right now we have to call in to verify if someone's still eligible, and we call the carrier for that, or
yeah, there's only a few carriers that'll really help you out. WellCare and Devoted happen to be the two that are really can get it to you pretty quickly.
Okay. All right, cool. And I just call in the agent number and there will be a prompt. Just follow the prompts and they'll help me figure out a Medicaid eligibility.
Mm-hmm.
Okay, cool. All right, perfect. All right, cool. All right, cool. And I don't want to dig super deep on that right now. Again, I just want to just kind of go over like the basics right now and show everybody. All right, cool.
Yep. So then the next piece of information that you kind of have to know, that's not going to be a question you can ask her, is based on what you've seen in the first box. She's on MAPDs. Let's just say, I found out that she had Medicaid, so I will look at Medicaid plans, which is in the plan information. You have to kind of, based on the information you're given in that first box, decipher what type of plan and the plan information that she has. An MAPD, a PD, this program isn't built out to quote med subs yet. It will be in the near future. There's a couple on there now, but it's not all inclusive. So I don't use it because it doesn't always give you the best med subs in that area. We have other quoting tools for that. But so basically the 4 that we're going to use is MAPD, PD, MA, special needs. Your dual plans are always going to be in special needs category because that's what they are. DSNP, dual special needs plans.
Okay, so basically, if I'm like, hey, are you on Medicare and Medicaid or just Medicare? If they say Medicare and Medicaid, automatic special needs is what we're quoting.
Uh-huh.
Okay, cool. Now, if they say I'm just on Medicare, then we're looking at
MAPD.
MAPD. And then depending if they're super healthy or not, is if we would look at potentially considering a med sub.
Right. But again, you wouldn't use Sunfire for med subs.
Okay. All right. Perfect. Cool.
Yep.
Good.
The only other two that you would ever run into here than use the PD and the MA is PD is just prescription drug plan. If you have a med sub's just healthcare. It does not have prescription coverage built into it. You also have to have a prescription drug plan. So that's when we quote out PDs. And then the MAs, which is Medicare Advantage only. That's why there's no PD behind it. It has no prescription drug plan built into it. Those are 98% of the time, those are used for veterans because they get their drugs through the VA.
And that was the MA?
Yep. Medicare Advantage only, MA only plans.
And that's if someone, a veteran, doesn't want to go through the VA for everything, they want to buy some of their own outside healthcare?
Nope. They would, only time you would ever put somebody in an MA only plan is if they continue to use the VA for everything.
Okay.
This basically, we're getting real deep in a lot of stuff that might be advanced selling, but MA only plans, when I sit down with a veteran who typically they don't have to have Part A and Part B Medicare. A lot of them will have A. Most of them will not have B because they get their B for free through the VA. They already get their hospital and medical, or their medical covered through the VA. So a lot of them won't pay for B. So, but if they do, you can put them in an MA only plan because it doesn't affect their VA benefits at all. Really, all it gives them is a card with a whole bunch of extras. Give back plan. I mean, some of them have give back, $75, $150 give back, food cards, utility cards. You're basically giving them a card that has a whole bunch of free extra stuff on it, and that's all they're going to use it for. They're not going to use it for their medical or their prescriptions.
Okay. So if somebody gets a utility card, it's, I would assume, kind of similar to like a Direct Express card, and then they can give that number to the utility companies and they can pull it off. Their utilities can come off of that card.
They would not give it to the utility company. They have to go down to like a Western Union and set it up.
Okay. All right. Okay. And so then let's say they get the money on the 3rd, then on the 4th, the money they have to make sure they have to go every month, or once they set it up once, it can automatically keep coming.
Once they set it up, I think it's good. I've actually never had any clients tell me how they do it, to be honest with you. I know every carrier is different. Some of them, I think some of them you actually have to go down and pay on a monthly basis. Like you're going to submit a Western Union to your utility company. You would just pay for that cash transfer with your essential extras card with your utility money.
Okay. All right. So it's basically like if they're getting extra help, let's say, they're going to get a utility card, whatever, like, hey, you're going to get the card in the mail. All the instructions on how to use it are going to be there. If you get a jam and you can't figure it out, the carrier can't help you, call me then, basically.
Yes.
Okay, cool. So basically when it comes to extra help, and like once we enroll them, they tell them, hey, look, the carrier is going to give you all the instructions and they're here as a resource. That's their wheelhouse because they know the ins and outs of their own food or utility program the best. Contact them. If you're still in a jam, call me then.
Basically. Yep.
Okay.
Yeah, I try to be available, but at an arm's length, if that makes sense. You know what I mean? Like, hey, yeah, call me if you ever need anything. However, 90% of your concerns and your questions should be directed to the carrier, just because that's what they have staff on call for that, and they're gonna be able to give you the most up-to-date, best answer.
Okay. Very cool. And that kind of seemed like that's kind of what I figured would be the way to handle it. So, all right, cool. All right. So now we kind of got like the basic of like understanding of, hey, when you're sitting down with somebody, what you're going to be picking. Let's say now that you've got, okay, so we've established for Medicare, Medicaid, this is going to be special needs. All right. Now where are we at? Now what do we do next?
Yep. I scroll down and just ask them. And it is, I mean, the devil is in the details. Much like you said earlier, one of the reasons why you kind of steered away from Medicare was just like how detail oriented it was, and you were kind of afraid to make mistakes here and there. That's everybody's reasoning for not jumping, feet first into Medicare, because they hear horror stories of agents getting things wrong and like really impacting, the beneficiaries' drug costs and all that stuff. So I will say this: when we get to the drugs and the doctors, the 2 Ds, make sure you uncover every stone and ask every question. And, you being a final expense agent, there's nitro that's in the cabinet that they never get out. There's stuff in the fridge, injectables. There's occasional inhalers that they don't really use, but they have on hand. We need to know about all of that. So that's kind of like how I handle the drugs. Like, hey, go, and I don't like to go off lists because lists can change. Lists can show medications that are non-generic medications because that was what was prescribed, and then the pharmacist changed it to a prescription that was a generic because he gets to see what your insurance company will approve. And sometimes they won't approve the brand name drug if the generic is available, right? So doctors lists are a no-go in the Medicare world. I want to see bottles. Go get me your bottles. Everything that you take, I need to see the bottle.
Okay. So, and then when you're sitting with them, if they're seeing, you want to know the name of their primary doctor, their kidney doctor, their throat doctor, their lungs
Yep.
doctor, any
If
doctor.
you see a doctor, if you see somebody that has doctor in the title, I need to know about it.
Okay, but it's cool. So any doctor you see, whether it's once a year or 5 or 10 times a year, I got to know the names of them, right?
Yeah. The
Okay.
only ones I never put in there because sometimes they'll have had a hip surgery and they went to see an orthopedic specialist that it was 4 years ago, but they haven't been back to something. I stress so heavily that I need to know every doctor. Most of those people, that's why I get that. People are like, oh, well, I have an orthopedic specialist. Okay, when did you see him last? Well, I had my hip replaced in 2019, but I haven't seen him since. Well, okay, I don't need to know about that. I mean, I need to see doctors that you're currently, seeing. But this isn't all. Yes.
All right, cool. If so, anything if it's something they only see here and there, we don't need to worry about that if it's not for a regular thing. But if it's any type of regular doctor visits, you've got to make sure we're getting them out, get them all. All right, cool.
Yep, and that includes ophthalmologists, like eye doctors, ear to audiologists, stuff like that. All of that stuff matters. If it's a doctor that their insurance is going to have to pay for, we got to make sure that their insurance actually covers that doctor.
Okay. Cool. All right.
Cool.
So now that we got all the doctors' names, and so for Miss Dawn, I assume it was those 5 doctors. All right. We got all those in. All right, cool.
Yep. And then we go down to the medications. She wasn't on a tremendous amount of medications. I mean, this is pretty run-of-the-mill stuff for a 65-year-old, You got a couple blood pressure medicines, a thyroid medicine, and then a mood stabilizer. So just plug those in. And I will say this is where we really have to do our due diligence. And I will tell you this, the biggest pitfall that I see or problem that most agents run into, especially new agents, because when you choose, and I'm going to edit this amlodipine Besselet and let you see what all pops up. Boom. So I'm going to rate. So that's what she had was amlodipine Besselet. But look at all these. Well, shoot, that wasn't a good one. Some of them will have 30 different options. That's why I want to see the bottle. I need to know that it's a tab versus a capsule. Most capsules aren't covered. They don't cover capsules if there's a tab available. Occasionally, that you really will find that you have to put in a capsule. But most of the agents that call me with problems are like, Mike, I'm sitting in front of Donna and her drug costs are showing like $10,000 a year. What's wrong? Okay, something's not on the formulary. Let's take a look at that real quick and see which one it is. And as soon as they send me a picture of their screen, 90% of the time it's because they've got a tablet. Instead of putting like a 2.5 milligram tab, they put a 2.5 milligram capsule and it's not covered. So it's out of the formulary, meaning you're going to have to pay for it out of pocket in full.
Okay. Now, are they, because I know like the older folks, just kind of gets harder to get to the pharmacy. Is there a way that when we're doing this, we can quote it from mail order pharmacy?
Yes. So we'll get there in 1 second. So let's make sure that you pick every medication, or you put every medication in, pick the correct, dosage, and then the frequency and the quantity. Again,
drop down and see what we can see what the frequencies are, because I know some people they only get their nitroglycerin bottle refilled when they run it through the wash. So if they do that once every 3 years, then just put once every 12 months.
Yes. Yep. That's making a good educated decision right there. Obviously if it's something that they might only, like nitro is one of those things that it doesn't get replaced until it goes bad, a year or 2 years down the road. So yes. But most of 98% of what you're going to run into is a 3-month, 90-day fill, right? You're going to get it for 3 months. Quantity is going to be 90, but not everything. But as you can see on hers, that's what she had on every one of hers. Most pharmacies and insurance carriers, that's their preferred amount to fill is for a 3-month fill. And most people only take one pill, except for like metformin. People take 6 of those pills a day most of the time. But and again, just whatever you run into, read it off the label of the pill bottle, plug it in accordingly. And then, yes, down here, here's the pharmacy information that you were asking about. Do they have a set pharmacy that they want to go to? Yes, no, mail order. She likes CVS. I will say this down here, this focus question area, it's irrelevant. I mean, you could punch all that in, but it will dictate what plans you're going to see in what order on the next screen. Now, if somebody absolutely told you that they needed extra vision coverage or insulin savings or whatever, but all of that's available on the next screen anyways. So I normally don't fuss with it on this screen. I just go view all plans from here.
Okay.
If I need to filter based on, something like that, as you can see over on the left-hand side, you can filter by any and all of those things that you could have filled out on the other questionnaire.
No, I remember somebody talking about it. Like the biggest reason that we want to be like making sure that we're replacing plans is because they've got putting people in a 5-star rated plan, correct?
Yes, but you know what? Just because it's 5-star rated doesn't make it good for Miss Donna. I mean, it could literally be a 5-star rated plan and none of her doctors be in their network. That wouldn't be advantageous to put her in that plan because you're going to get a complaint and a call back real quick.
So the only time, like realistically, I mean, the only time I really need to do a scope of appointment, is if I call up Miss Donna and she's not a client, and I'm like, "Hey Donna, this is Mike. I gotta request you. We're looking for some information on getting some extra help or blah blah blah, whatever. We need to set up a time to talk." That's when I need a scope of appointment. That's when I've got to fill out everything and make sure I put the reason why I changed the plan.
So, per CMS ruling at the beginning of 2024, going forward, so all of this year going forward, you're supposed to have your scope of appointment filled out 48 hours before you actually sit down and go over plans with Miss Donna. So the cool thing is, and I guess, you know what? That's a good question because I skipped over doing that in the
Yep.
yeah, doing this. The very first screen, and I'll back out and I'll show you once we get out of here. I just don't want to mess up too much stuff. Where I hit quote and enroll on the far right hand side of that screen, there would have been scope of appointment button. If you hit that, you can actually email, text message, email or text message a scope of appointment to Miss Donna, and she can fill it out and send it back to you. And it'll be saved right here. So you can do that. If you're calling and making appointments, have her do that. Send it over to her. And I know a lot of our clients don't have the ability to do texts and do emails, but technically, I mean, again, compliantly speaking, that scope of appointment is supposed to be filled out 48 hours before we sit down and go over plans.
Okay. All right. Now, granted, if we door knock, it just we can just do it right and just do it while we're sitting in front of them.
That would not technically be 48 hours prior to the sit down, and that's what compliance is. So for lack of a better way of saying it, there's ways around all that. We can go over that later. I typically,
I know where you're going with it. I have an idea.
Yeah. Okay. I date the scope of appointment for what date I needed it to be dated.
Exactly. It's exactly what I was thinking.
Between you and me and whoever watches this. Yes, that's kind of how that goes. So let's just pretend the scope of appointment was already done and I'm sitting down with Miss Donna and all is right in the Medicare world.
Before we jump on, like, just so everybody knows listening on this, you need to fill out a scope of appointment and have it dated for the day that you're there and make sure it's compliant. You need to do one in every single house because if you get dinged and something happens, you need to be able to show that you were compliant and you had your paperwork ready.
Absolutely, because the first thing a carrier is going to ask for above all, show me your scope of appointment.
So if you don't have that, you're going to be in real deep trouble with the carrier.
It's
So
going to be real hard to talk yourself out of whatever's been brought to their attention without a scope of appointment.
basically what this means, guys, is when you sit down and you're looking at your iPad and you got Notability pulled up in front of you, what you need to do is you need to go through and fill out a scope of appointment first. Then we do our client data sheets, right? Take down all our information. Then we can plug it all into here into Sunfire. So just guys, when you're doing Medicare stuff, put a blank copy of a scope appointment right in your client file, your blank one, and that way you know to do it. It's staring at you directly in the face.
Correct.
So, all right, now that we got all out of the way, I just wanted to give my people, just really kind of give my people some feedback on that to make sure they understand, like, hey, it's very, very important. All right, cool. So now we're looking at the plans right now.
Yep. So here's the plans. So here's what I hate about Sunfire, and I wish it's set up this way to be dummy proof. They don't want somebody, maybe a newbie that's not sure of the plan types like MAPD, PD, MA, special needs, to be able to quote and compare the wrong type of plan. And what I mean by that is this. So that's her current plan.
Okay,
In
so
which
where did you click on her current plan? Where did you find that?
it's always going to be at the top. If you've plugged all that information in the previous screens correctly, it'll show her current plan right at the top.
So the system, so Sunfire will be able to see based on her red, white, and blue number that is the current plan she is enrolled in, correct?
Yes. See how it says current plan, top left corner?
Yep.
Okay. Yep. So she is currently in this Aetna Medicare Premier HMO POS. Super good plan in her area, not in her best interest, being that she has Medicaid. So here's what I was going to say. Because this is not a Medicaid plan, it will not allow me to screen share and compare the details of the plan. And like I said, they do that on purpose. See right here where you can show compare, and then I can pick other plans.
Where it says UHC dual. All right, hold on. Where did you see compare? I might not have seen it.
The little compare when you expand the details, the snapshot details of the plan that you're looking at, like that UHC down the bottom left of the corner, it allows you to click on a little button.
The little button. Okay, yep, compare. Okay, cool.
And you should be able to compare 3 plans at once. Okay. The unfortunate part is because this current plan isn't in the plan type that we're supposed to be looking in, it will not allow us to compare next to the other ones. It just won't, because it thinks we're doing something wrong.
Okay.
And then that they're never going to change it because it is supposed to be a foolproof thing. Oh my gosh, why can't I compare these two? Well, because technically you're comparing 2 different plan types and you shouldn't be. Because they either have a special needs, or they have an MA, or they have an MAPD, and you should be only looking at the selections in that plan type that they're currently in. However, somehow she's picked up Medicaid somewhere down the line, and she now sorry, I keep getting texts from agents while I'm trying to talk. So I have to look at special needs because that's what's in her best interest, but it's not what she's currently in. So unfortunately, the system won't allow us to filter and plan or compare side by side 2 different plan types.
So now that we see, okay, so this is her current plan that she's in right now. Let's close this out. Now we're just going to see the whole list of plans that are coming up right now. Is it in chronological order of what Sunfire feels the first plan, that UHC plan? Is that what Sunfire feels is going to be the best one for her, or do we have to go through and kind of read, or does it?
That's a yes and no answer. So yes, it does feel like this one is the best one for her based on estimated annual cost, which is the thing in the top right-hand corner right there. It does not take into fact with what the max out of pocket is, what the copays are, whether the doctors are in or out of network, right? It is only taking into consideration which plan is going to cost the amount through the course of the year.
So that it's our job to open up every single plan, open, look, and see, okay, do we find one that has 0 copays? Do we find one that has 0 out of pocket for medications? But do we also find one that has all 5 doctors in network?
Correct. That is up to us to take their recommendation, but then go, do our due diligence, go a little deeper. So I will tell you that if you see this Dr. Lori Belknap is not in anybody's network, that's because she technically isn't in anybody's network. You can't always go by, I wish Sunfire was 100% accurate. It's not. If it tells you that somebody's in network, rest assured they're in network. But when you see that no location is in network for Lori Belknap or this William Wainwright, if you think that this UHC is the best plan for her, what I would suggest to do is go to the UHC portal page and actually go into their doctor registry and make sure that that doctor is or is not in network, because there's times where they will be, even though this says that they're not. And it just has to do with how doctors come in and out of the networks. I mean, because they could technically leave UHC's doctors or like their approved network in the middle of the year. You know what I mean? So that is the most up-to-date information that there is on the actual portal page for the whatever carrier you're looking at. So like for her, you look down through here, I'm just going to go quickly. None of these plans in her area show Dr. Lori Belknap being in network. Hold on, I got to sneeze. And cough, apparently. Ugh. Fighting a little bit of a head cold this week. I ended up going on every one of those portal pages quickly, obviously a little easier for me than a newbie, and checking all the doctors that are showing out of network. And it ended up being that I ended up putting her in this Humana Gold plan. Humana Gold, one of the Humana Gold that I'd have to look at.
Plan was because you ended up finding that the Humana one covered all their doctors and it was still the lowest cost. What made you choose that one?
Well, honestly, based on doctors in network, right? Like it was a pretty clear cut thing. I can't put her in any of these UHCs because both of those doctors were out of network. And that's for all the UHC products. So I took all those off the table really quickly. Boom, let's just collapse them. Then looking at the Anthem, Lori Belknap was not in their network, so we took that off the table. And that's going to be the case for all of their Anthem's dual plans. The only one that had, and I had to go to the portal page to verify all this, the only one that had it was, in fact,
like are you moving around a lot over there or something? It's like the microphone's like getting fuzzy in and out quite a bit.
I think I might be putting my hand on it. Sorry.
Okay, yeah, as I say, it's I'm not sure what it's doing.
I was grabbing the iPad to hold it steady while I was scrolling, and I think I'm putting my hand over the microphone. Sorry. So yeah, it was the Humana. I put her in this 087 plan right here, which is the best of the best of the best right now. And for her in this area, and it really, as you see, she's going to have to pay some for her drugs. The estimated annual cost is $48. If you can see right here, that $48 annual cost, obviously there's $0 premium, there's $0 copays on everything. It is that full $48 is coming out of drug costs, copays at the pharmacy when she goes to pick up her drugs. Now, as you see right there, Sunfire updated this about a year ago. If there is a cheaper, because CVS is not a preferred pharmacy with Humana, it's a standard pharmacy. If there is a preferred pharmacy or a mail order option that saves them money, it will say that right there. And then you can actually have that conversation with them. Hey, is there any particular reason why you're using CVS, Miss Donna? Is it local? You like it? And I did. And because I told her, I said, mail order. She's like, no, I live in a not so good neighborhood, and she doesn't want her drugs sitting on the front porch while she's, gone for the day by chance. So I said, cool, completely understand that. And she doesn't like any other pharmacies in her area but the CVS. So boom, that was kind of like a cut and dry conversation real quick. The reason why we went with this one, again, is because all of the drugs are in her area. All the drugs all of her doctors are in network, sorry. But let's compare all of the Humana products together, and I'll show you the difference between why I chose the 087 over the other two. So basically, as you can see, straight across the board, they're all 4 stars. One of them's a PPO, 2 of them are HMOs. There are no medical deductibles for the first 2. The second one may have some in-service or in-network services that she would have to pay a deductible for. because this one is technically for low-level Medicaid, and they have some cost sharing sometimes. So, but the rest of the parameters of this plan are basically identical. So moving on from there, I would take a look briefly at just all the different side-by-side comparisons. Like, she's probably not going to get acupuncture. Here's the other thing that I'm going to tell you. Don't feel the need to explain the acupuncture in-network costs and co-insurances to somebody who doesn't even get acupuncture. Most of these benefits go unused. I'm not saying don't bring them to light, but don't feel what you'll do is overeducate your client and turn their brain into mush, and then they don't want to move anyways because they feel confused.
Yep.
I talk about relevant benefits in the plan, like what's relevant to them based on the conversations we've had up to this point, and that's what I pick and choose what I'm going to talk to them about. And the fact of the matter is, in these dual plans, most of this stuff is the same cost anyways because it's all picked up by Medicare and Medicaid. As you'll go down through, you'll see ambulance services are always going to be zero across the board. Chiropractor services, if they actually are allowed to have those in their plan, they get 12 of them at a $0 cost as long as they stay in network. So down here, I will show you. And so for this one, that middle plan actually has better dental, $3,000 dental versus $1,500 dental in the other two. But guess what? Miss Donna has a full face of pearly white dentures. She doesn't care about the dental. So I could tell they were dentures, but I'll say, I was like, well, Miss Donna, look, you have some pretty pearly whites over there, but I don't think you probably need this dental. She's like, oh no, honey, I've got dentures. I don't need the dental. Okay, so let's move on to, again, what's relevant to her. So in these dual plans, like I said, all of this stuff is covered at $0 copay or $0 premium. So when we are looking at dual plans, the differentiating factors, like we said in the first series of these videos, is typically the free stuff that's built into them. So scrolling down, all of this stuff is the same cost for all of it. And it's all zero because it's a dual plan. We will go down to the over-the-counter. This is why the 087 plan stands tall. That is a $250 card every month that gets loaded, and they can use it on. It doesn't roll over month to month. Most don't. Some carriers do allow rollover. Humana does not. So it is $250 every month they've got to use. That will, and I will scroll down to the bottom and I will tell you what real quick, that $250 they're allowed to spend it on. It'll tell you right here. Eligible members receive $250 a month for essentials like eligible groceries. Groceries are supposed to be healthy foods, fruits, vegetables, dairy, meats, fish, etc. However, I've had some clients tell me, especially with UHC, that they buy Mountain Dew and beef jerky, and it goes through because it's classified as food when it gets rung up. So I don't tell people that. I let them find out those little loopholes on their own. Just tell them it's supposed to be good for good, healthy foods. They can also get
a store, like they give them that card. The grocer will automatically be able to recognize what the card will cover. And
it'll be in their system. I mean, as soon as you put they'll scan the groceries, they'll swipe the card, it'll pay for what it's going to pay for. The difference is due by you whatever other form of payment you have. You can do utilities, rent, and pet care. So Humana is one of the few that actually covers pet food and like kitty litter, stuff of that nature. So again, and I don't need to go back up too far, but even if we look at like in-hospital care and all that stuff, all of it's zero. So in this situation, I already knew the 087 was the best of the best because I've been doing this for quite a while now, but everything in this plan, these three Humana plans, even though they're dual plans and they're all in her network, only one of them had more free stuff built into it, right? One of them has $1,200, one of them has 18, the other one has 3,000 over the course of the year. It's a big difference. And I wouldn't ever, and there's times where unfortunately I run into Miss Donna's already in this and it's the best thing that she can have. And I'm thinking, man, if I could just move her to this for just a month or two, guess what's going to happen? I'm telling you, I've had clients actually tell me, Mike, and I'll shoot them straight. And they'll tell me, Mike, I don't use all that 250 anyways, but I really would like for you to be my agent. If we can have that conversation and they're saying, hey, I will take that $150 food card for a couple months and then move me back to the $250 card next quarter because dual plans are allowed to move quarterly, I'll do that. But I would never do that without my client giving me their full permission having that conversation, because it's a surefire way to get a complaint really quickly. Because most of these people use every last cent on that card to get by, not just to thrive, to survive on a monthly basis. And when some of it's gone, you're going to know about it. And so is CMS, and so is Humana.
So the only way that like it would you would do it if they were like, hey, I don't want to stay with my agent, I want you as my agent. Then we have to show them, hey, look, the only way we can really make that happen is we basically have to downgrade your plan for 3 months, and then after 3 months, we can upgrade you back into that same one, and then I'm that same plan again. And I'll be your agent.
And Mike, it technically doesn't have to be 3 months. It just has to be in whatever quarterly. Their quarter runs January through March. So right now we're in May, so it would be January, February, March, April, May, June. So technically, let's just say Miss Donna, that she was already in the 250 and I was moving her to the 150. I'm going to put her into the plan for 6/1. She's only going to have that plan effective for 1 month, because on 7/1 starts a new quarter. So she really only has to have that plan for a month, and I get her my book of business. Now, of course, you get a charge back on one, and then 2 months worth of commissions on the other one, so it washes and pays for itself. But what you did get was a client in your book of business.
Okay. And then you just got to make a note, hey, in 3 weeks or whatever it is, go back in there and will me.
Absolutely.
Yeah. All right, perfect. That makes sense.
Yep. I'm not saying that conversation is going to go that well always, but I've had some clients, man. What you're going to find out, Mike, is the vast majority of the clients that you sit in front of, they've enrolled over the phone. They've never had an agent. They don't have anybody locally. They prefer to work with somebody local that they can put a face and a name to, or a face to the name. And so they're actually more than willing to kind of put themselves in a position like that, where they're losing a little bit to gain you as their agent, and then get it back later. I've had plenty of clients tell me that.
Yeah. Oh, that makes sense. So then there's no way, like, let's say, the agent is some over the phone agent, they haven't talked to him again. There's no way we can go in there and change that agent of record on that 250 plan, right? Well, you can, you just don't get paid for it, right?
Say that one more time. I'm trying to make sense of what you're
Let's
saying.
say they really want to stay in that 250 plan, but they want you as your agent. Can you go in there and file an agent of record change and get that person in your book of business without having to de-enroll them, put them in a lower plan, then put them in a newer one? Can you just have the agent of record change and get the renewal changed to your name?
Yes, not with every carrier. There's only 3 carriers that do that right now, and it's 3 that we barely write: WellCare, Aetna, and Cigna.
Okay.
Other than that, there is nothing you can do to get them to approve AOR changes at the big 3, Anthem, Humana, and United Healthcare. They will not do it.
That makes sense. All right. That's what I wanted to know, because like I know in insurance you could do stuff with agent records and all kinds of different stuff.
Sure. Yep. Used to be a thing, stopped being a thing a couple years back.
It probably turned into a shit show of everybody trying to.
It did. That's what it was. It was just people. They were tired of doing paperwork, switching people from one plan to the next plan and back again, and just doing AOR changes. So yeah, that's kind of a thing they did away with. So Miss Donna is a pretty simple case. Like, she didn't realize she had Medicaid. I will show you. So let's go back real quick to the plan that she currently has. As you can see, yes, she didn't pay anything for her drugs. She didn't pay anything for a monthly premium, but she did have quite a few specialists, if you see down here. 1, 2, 3. And actually, Erin Garrison is not her PCP, even though it's listed as a PCP. She's specialist. So there's 4 specialists that she sees throughout the course of the year that she was going to have to pay a copay on. I took that copay away. And the reason why her drugs went to 0 is they're all covered, but they're at a preferred pharmacy. So that actually lowers, typically when you go with a preferred pharmacy, it lowers the cost of your copay on your drugs. So all of that's basically, drugs were cheaper, but I will show you what really made the difference for her is like, hey, one thing is basically all those crazy services, chiropractor, dental, whatever it may be, like everything costs money in these MAPDs. There's a copay or a co-insurance basically tied to any of that except for her PCP doctor visit, which is right there, $0. But everything else was costing her money through the course of the year. Whereas on a dual plan, you've seen all that stuff was $0, $0, $0. And here's the big one. So her over-the-counter card that she gets is only for over-the-counter items, health and wellness products, as it says right there. No food, no utilities, and she only gets $135 a quarter versus $250 monthly. Like, it was a no-brainer. She almost started crying, and I said, the unfortunate part is, Miss Donna, I don't know when you got Medicaid. You might have had it for 10 years. You might have got it yesterday. There's no, because she said, you mean I could have been on this good plan for how long? I'm like, the how long part, I don't know. But yes, you should have been on, at least going forward, you will be, Okay,
cool. Well, this all makes sense. And I definitely see how, like, now looking at it, it really makes it relatively pretty easy. You just got to take the time to read the fine print and see what's better that's out there.
Yes. And again, so on the, let's just say that she didn't qualify for a dual plan. She didn't have Medicaid. Let's just look at other MAPDs because that's technically what she's in right now, is an MAPD. It's funny because this is going to tell you in descending order, best to worst, as Sunfire sees it, as money out of pocket. Obviously, if all the doctors are in network, they're going to stay in network. But it's showing estimated annual cost of $0. As you go down through here, I would assume some of these will be, boom, there you go. That one has a monthly premium. Even though the drugs are $0, she's still going to end up having to pay $150 over the course of the year because she has a $12.50 premium. Plus, her specialist was more expensive. So dude, Sunfire makes our job so easy that a trained monkey could do what we do. All you have to do is be able to plug in the information to get to the plans and then compare the plans side by side. I mean, how easy is that? Where you just go line item by line item and you see which one's better. Now, in this case, let's just say I was sitting with Miss Donna and she didn't have a dual plan, or she didn't have the eligibility for a dual plan and she had to stick with an MAPD. The one on the left is her current plan. The one on the right is her the next best plan for her. $0 monthly premium. Cool. That's going to stay the same. Now, this other one does have a lower max out of pocket, which is good. You want as low a max out of pocket as possible. That is your ceiling, to where if it hits the fan health-wise over the course of the year, you're never going to have to worry about paying any more out of pocket than that. So you want that number to be as low as possible. And obviously it is, $1,050 lower than the plan that she's currently in. But I will tell you this, you have to have a fairly catastrophic year to get up to your max out of pocket. Most people never even come close to paying that. Even with going to the regular doctor's visits, maybe a hospital visit or so here and there, they don't hit that. So as long as it's within reason, it's not like 4,900, 9,000, the difference being, double the cost. If it's within $1,000 or so, that's close enough for me, if that makes sense. Because the likelihood is they're not going to see it anyway. So they're not going to hit it. I wouldn't like this plan. It has a drug deductible, excluding tiers 1s and 2s. That I would tell Mastani, this plan, basically, you're going to have to come out of pocket for the first $400 on your drugs through the course of the year for any drug that's not a tier 1 or a tier 2. Now, the reality is maybe all her drugs are tier 1 and 2. Let's look at that real quick. They are. So this is the formulary. Amlodipine a tier 1. Losartan, tier 1, atorvastatin 1, levothyroxine's a 1, paroxetine's a 1. So kind of disregard what I said, but we didn't know until we did the due diligence of looking. But that $400.
Where did you go to check the drugs? What's your
top? Drug cost detail right there.
Okay.
Did you see it? Right here?
Yep.
Oh, shoot.
I see it. No, I saw it when you went back to it. I saw it, so that's cool.
Okay, cool. And it tells you the formulary. Boom. And if you go even further down, it gives you a month-by-month breakdown. Again, assuming that you're taking this plan in January, and that would be your first month for filling all of your drugs. Now, for her, it's zeros across the board. But let's say some of these were 3s and 4s, it would give you a month-by-month breakdown of what she's going to pay on a monthly basis when she fills those drugs. Kind of nice. Okay. You can expand it and go all the way through. So let's go back to the plan details. because the drugs are all the same. They're all free. Just scroll down through here and start looking at all the different benefits that are available. Silver sneakers built into both of them, which is really good. What is this? Okay, so ambulance ride. The current plan she's in has a lower ambulance copay. Chiropractic care is a little lower. She gets a little bit more on the dental, $2,200 versus $2,000. She's not diabetic, so I wouldn't go over diabetic supplies. Diagnostic tests, labs, radiology services, and x-rays. That's something that they, x-rays and MRIs and stuff, or lab tests for like blood work, that falls into this category. So I would kind of take a look at that. Most of that stuff's pretty cheap, and comparatively speaking, back and forth, it looks like it's kind of give and take. One's a little better in some and one's better on others. But not so drastically different that you really have to worry about it. That's the thing. When they do differ, they normally differ by $5-10. So if it's back and forth, where this plan has a little bit more on the specialist copay, but then the next one down is the emergency care is a little bit more expensive over here. You just kind of got to weigh out which ones are going to factor more often. You can't guarantee that she's going to go to the emergency room at all, but however, she did have a lot of specialty doctors. So that copay is a reality for her. So we got to add that up a little bit. How many times of the year do you go to the specialist? Is it enough to where $5 every time you go is going to really impact your wallet? But it's simple conversations. That's one of the reasons why I tell people Medicare is not black and white. Like I feel like life insurance really is. Okay, here's your health. Here's what you qualify for. Here's your 5 carriers. Of those 5 carriers that will accept you, here's the one that has the lowest rate or the best benefits for reasonably lowest rate, right? We were never going to put the most expensive rate in their hand. Sometimes you might see a carrier have a little bit better living benefits in it, and it's going to cost you a little bit more. And I'm not trying to compare apples to oranges here, but I say all that to say this. I feel like a life insurance comparison or a life insurance policy, pretty black and white. You either qualify or you don't. Here's the premium, in which case we're going to try to give you the best bang for your buck. In Medicare, it's give and take. It's a conversation. What can we do? None of these plans are just knock your socks off, the best thing out there. There's always good. The one you're going to compare it next to is, for the most part, always going to have a little bit here and there better benefit. That's why so many clients are able to get on a phone call with a call center agent and get switched, because that call center agent's going to leverage the 1 or 2 things that he sees different that are better in the plan he's trying to sell, and wrap that up in a pretty package and get Miss Donna to agree to it. You know what I'm saying?
Mm-hmm. Yep, absolutely. That may make sense. They're looking for any single thing they can see better, and let's switch it.
And like this one, I wouldn't put her in this one at all. Because it's just not knock your socks off a better plan. And most of she has better dental. Her ambulance services were lower. But right here, if I was if I was trying to get her to switch, I might leverage the fact, oh my gosh, you said you have 5 specialists, Miss Donna. If you see each one of those 3-4 times a year at $5 extra a pop, we're talking triple digits now. We're in the extra $100 to $200 a year that you're paying out of pocket to go to see a specialist. Could that money back in your pocket help you somewhere? Help pay the light bill, help put food on the table. You know what I mean? Like, if you want to be a salesman, you can sell. That's just how these seniors get flipped from policy to policy so much. And I say all that to say this: keep your current clients keep attention. Be attentive with them. You definitely want to stay in contact with them through the course of the year, because I promise you, if you're not, I say it like this to all the agents that I train: if you're not touching your clients, somebody else is.
Yep.
I promise you. You see me, the way I just spun that $5, she would bite on that instantly, and I could have made that move.
Yep, absolutely.
But as I scroll down through here and look at the details of the plan in its entirety, looky here. I would have talked her out of a $135 OTC card and put her in this $50 card, but I probably, I wouldn't have been doing her any due diligence, because the money she's losing on this over-the-counter card that's paying for all the essential extras, more than covers that $5 extra on the copay for the specialist. But it's all based on a conversation. And again, like I said, none of these are back and forth, or none of them are ever going to be, oh my gosh, every aspect of this plan is night and day better, right? It's going to be give and take, which gives us the ability for some wiggle room to do what we see is best for our clients, I guess is what I'm trying to say.
Okay. That makes
sense. The only thing I don't like about that plan is if she goes into the hospital, she has to pay $550 per day for the first 5 days before Aetna starts paying. And then from 6 to 90, she would pay $0. Over here, it's only $350 a day. So she's not the most unhealthy person, but a couple-day hospital stay in this plan over here would more than upset any savings that she may have gotten.
Yeah, well, for sure. I'm looking at that right. And that's kind of, I was like, well, no matter what, it's that right there alone could be a huge differentiation.
Yep.
All right, cool. All right, so that I think that's a good place to stop this is for today. It's like, looking at what the big things that we need to look at, kind of how to read and understand what the what the best thing to do is. And I would imagine that you probably learned, Mike, by just getting in the field and doing it and then calling, whoever your upline was, wherever you were at, man, like, hey, this is the current plan they're in. This is the plan that, I see as the best. Can you help me out? Or how are you learning and doing that?
Man, you kind of hit the nail on the head. When I started this, I've been running Medicare straight for about 4 years now, but I took about a year and a half off. I started about 5 years ago in Medicare, and my first year running, I was saying, yeah, maybe I've only been doing it again for like three and a half years, but irrelevant. What I was going to say is this: when my first time running Medicare was during, was during AEP of 2019 or 20, I think it was 2020. And I just got all my contracts, got licensed, ready to go the week of AEP starting. And I went out day one AEP. And at that time, I didn't know hardly anything, man. And Waylon was still not even really doing Medicare Advantage. He was doing med subs mostly. So him and I basically said, dude, take this stack of leads, call me in every house. We'll make sense of it all. And we did, man. In 6 weeks of AEP, I wrote 100, in my first ever 6 weeks of working Medicare, I wrote like 112 apps. Yeah. It can be done. That's how I learned. I called him and I would be like, and I wouldn't tell these people I was a new agent sitting in front of them that just learned how to spell Medicare the week before. I basically said, oh man, we got this new operating system that we're running on. And just want to make sure that what I'm seeing is, in fact, what I'm supposed to be seeing. Let me call my boss real quick and see what he can see on his end, make sure all this is right. And be like, oh, okay, because they want to make sure that you're getting it all right. And I'd call Waylon and I'd be like, hey, man, here's what I'm seeing. Are you seeing the same thing on your end? He'd be like, yeah, give me their information. Let me pull that up real quick. And I'd shoot him the date of birth, the zip code, the MIB or the MBI number, and he'd plug it all in. And he'd be like, oh, yeah, that's exactly what I'm seeing. I think that's the one you should go with.